the area of surgery, given the surgical clips, that this could be a seroma which has higher attenuation because of secondary infection. Given its presence in the mesentery, this could be something like a desmoid tumor or a peritoneal deposit.
Okay. This is what we call a gauzy pipoma, also known as a textiloma. Basically, it's a retained swab. A retained swab is a never event in UK, and there are robust mechanisms because please remember to go back to the basics. The surgical gauze which is used is what we call barium impregnated. It has got a thread which is impregnated with barium. It's high density. And they've got robust systems to count and after the surgery count it again. And if in doubt, they will do a plain film there and then. Having said that, these kinds of things do happen. I've seen 3-4 cases in my experience. All of them were, had some surgeries abroad, and but you should be familiar with this. And the key thing is that if you do a plain film, you will see this high density to be metallic density as you have picked up. So once the radiology is quite tricky because what happens is you can see there are small air pockets within this gauze, and it all depends. Sometimes you will get this flocculent type of densities within it, and the air pockets can sit in for months and months. Sometimes it will be sterilized, and there will be no symptoms or anything. But the key thing is that metallic density. So think out of the box and think about a gauzy pipoma. This case has got, because of time factor, I am just going to ask you leading question. Now, there is a developing interception. Can you describe it, and what do you think is the cause?
So there is an interception. It seems to be there is a fatty density adjacent to the interception. So I think the most likely cause is probably a lipoma. Excellent.
So this lipoma is the leading tumor. It has, if you see the mesentery is going in, this is the lumen of the interceptum, and this is the interceptium. And you can see that this lipoma is the lead point which has taken it inside. And in the exam, you will ask the examiner, I want to do my densitometer, and that will be, that will confirm that this is a lipoma. This patient was scanned for mesenteric ischemia, that was the history, acute abdomen. And this is an arterial phase. What's happening here?
So there is hypoenhancement in the loops of bowel in the right. So there's also kind of free fluid. It looks like it's confined to the peritoneal reflection.
So this was a loop of bowel. You're right. And within that, you can see this high density. Which phase is this?
It looks like it's arterial phase.
What should you be worried about, and what will you ask for?
So delayed imaging. It looks like there's contrast extravasation. So I'd want a portal venous or a delayed phase, 90 seconds.
Before that, what is more important?
And an unenhanced to see if the high density was present before.
So unenhanced is the key. You have to ask for that. This is the unenhanced, and now what is your conclusion? That there is an active bleed. Your answer that I will also ask for a delayed is also a correct answer, because please remember that what happens when you do a delayed film, it will make the diagnosis even more certain. So for example, this patient had a polypectomy, and you can see this arterial phase, there is a bit of enhancement, so active bleed. Non-enhanced, there is nothing, and on delayed, it further spreads. So, but the key thing is to ask for a non-enhanced. Same scenario, they will also ask protocoling, because how will you protocol it? And these kinds of study, an unenhanced scan is critical. So this, I believe, takes us to the end of. No, still there are a few films. Okay, what is this?
So this is CT abdomen and pelvis in the portal venous phase. There is marked circumferential neural thickening of the transverse descending colon and the rectum. It has a sort, there's also ascites, and it has a sort of a pseudomembranous colitis sort of an appearance with marked colonic thickening with mesenteric hyperemia and free and ascites.
Right. So well done. So basically, this film is pseudomembranous colitis, but it can be a differential diagnosis. Now, this is from your book, and you should have a clear-cut concept about some of these things which I have pointed out. You know, your book tells you that colitis can be diffuse. When colitis is diffuse, the top two are UC and pseudomembranous colitis. In pseudomembranous colitis, the thickening of mucosa, they say, is much more than anything else, but that is not an absolutely specific finding. This is known as accordion sign, where look at this thickening and this is the mucosa. So other than pseudomembranous colitis, these things you have to remember, but UC, you should have a clear-cut concept about UC. So pathologically speaking, UC will involve anything, rectum proximally, but radiologically speaking, you will see in your clinical practice various kinds of patterns. And it can be diffuse, it can be predominant left-sided, ulcerative, and you might see UC, which is just rectal or proctitis is there. Other than that, predominantly right-sided Crohn's disease is important. Ischemic colitis. This particular type of ischemic colitis is a ischemic colitis where the SMA is involved. And if an examiner has this kind of a film, maybe on a CT, he or she is going to show it to you. Why? The concept. The concept is that, please remember that SMA supplies till about the transverse colon. So it is supplying the small bowel and the large side of the colon. So it's quite a unique finding where there are signs of ischemia in the small bowel as well as right-sided of colon. On the other hand, usually ischemic colitis in the large bowel is on the left side. And this is because of IMA, inferior mesenteric artery. So diverticulitis we have already covered, and radiation we have also already covered. Whatever I have pointed out, these are important for your exams. I am going to just go through them quickly because I have taught you this in the abdomen part, where the idea was that I have shown you various kinds of films which can come in the exam where something is sitting on the serosal surface of the bowel and is causing a desmoplastic reaction. So because we have already covered it, I'm just going to revise it. This is a classical case of metastasis. The metastases are sitting at the rectosigmoid junction here, and this is ovarian metastasis. And what happens is that when something sits on the serosal surface, two things are important for the exam. One is metastasis, second thing is endometriosis. And so if you see what happens here, that it is causing some indentation on the lumen is narrow. Because of the desmoplastic reaction, folds of barium are going towards the soft tissue mass, and the mucosal folds might be sort of fixed there. We call this striped colon sign. So metastasis sitting here, metastasis sitting here. Another case, and here you can see something is sitting here at the serosal surface of the rectosigmoid. But this one is endometriosis. Another example, and another example sitting at the ileocecal junction. I had also shown you this, showed you this MR, which is a very important exam case, where what is happening is that there is deposit of endometriosis at the rectosigmoid. Key finding is that this is low in signal intensity on T2 weighted sequence because of hemosiderin. In our case, there is a hysterectomy, and there is another deposit which is sitting on the posterior surface of the bladder. And you can well imagine that at the time of menstruation, this patient must be bleeding through the, there must be hematuria as well as melena. So same case is barium examination, and you can see this serosal surface indentation. And I also told you that malignancies, they appear high signal on T2 weighted or intermediate signal. So this is a deposit of the ovarian carcinoma metastasis, which is sitting there. Look at the signal. This is intermediate signal. This is low signal. So this is different than this. Spot diagnosis, candidate 4, just give me the diagnosis. What's happening? These two strictures, benign or malignant?
There is some shouldering and some mucosal irregularity, so I'm going to go malignant.
Excellent. So these are synchronous tumors, two tumors sitting there. Okay, final thing of this chapter is rectal carcinoma. How will you describe this?
So there is, on the sagittal, I can see circumferential but asymmetrical mural thickening of the rachmoid of the rectum with increased T2 signal. There is also some, it's eccentric and mainly between the 12 o'clock and 5 o'clock position. There's a bit of thickening of the mesorectal fascia. I can't see any surrounding enlarged mesorectal nodes. The fat plane between the prostate and the rectum is preserved, and the bone marrow demonstrates normal signal intensity.
So you said that there is thickening of the mesorectal fascia. Which sequence are you talking about?
I think I can just see those linear kind of low intensity streaks, just kind of lateral to the rectum on the axial images.
So what does it mean? So you're pointing out to this thing here?
No, just a bit more lateral. I can see those two lines. Just there, yeah, and the other.
What does this mean then?
I mean, it's not that thick. It means there's some sort of inflammation, but given the history, given the presence of that mass, then when you want to, in terms of surgery, you'd want to be telling them about it so they can excise, so they can have a clear excision margin.
So, what is the staging of this tumor, the T staging?
Oh, sorry, I don't have any ideas on that.
Okay.
But there is extra capsular, there's serosal invasion, because you can see it on the top, on the second axial imaging. It's the tumor infiltrates beyond the serosa, but is separate from the seminal vesicle.
Within the mesorectal fascia, mesorectal fat, and is there any serosa at this stage? My question is anatomy.
Is there any serosa? I don't think so.
Then, okay, what I have, you see, the point is that rectal carcinoma, candidate 4, Thank you very much. You can keep unmuted, but I'll take over. I'm going to teach you now about rectal carcinoma. Now, rectal carcinoma (MR) is now a pure exam case, and you have to understand. And it has come in the exam now quite a few times, and there can be vivas, etc. also on this. And in your day-to-day practice, those of you who are sitting the exam and they do not know how to report an MR, the best way is to learn something. Which, for example, I'm going to teach you something today, and do about 5 odd reports under your consultants, so that before the exam you know what you have to and how to tackle it. So let me go back to the basics. I think I am reflecting on one thing today. I wanted to finish GIT, which was very ambitious, because I'm going to teach you liver also in great detail. And as I'm talking to you, I had not designed my next Thursday's teaching. And what I'm going to do is that I am going to go a bit slow. This is what I have decided as I'm proceeding through the session, and teach you more. And next Thursday, I'm going to continue with whatever is left. And that will give me the time to give you a bit of quality on the teaching, because this rectum carcinoma is very important, and it will take a bit of time. Then liver MR will take a bit of time. So I will not conclude GI, but time-wise I will conclude. I will just stop at 9 o'clock today. And then whatever is left, I will continue next Thursday. So now, if you see the sequences of MR, rectum, these are the sequences, and this is what we do. This is what we used to do. We used to do a large field of view. When a case comes to you for rectal carcinoma, please remember, you should be given the histological diagnosis. So how does it happen is that the patient has already had a colonoscopy or a sigmoidoscopy. There was a tumor. They will give you the histological diagnosis. Number two, they will tell you that what level is the tumor. So they will say in centimeters, it is X centimeter from the anal verge, and they have to tell you this. And one black and white concept which you should have, that our role of an MR of the rectum is not diagnosis, is a staging, means that where the tumor is going and things like that. So I'll give you the concepts and the viva questions around it. When we stage a rectal carcinoma, we do local staging with an MR, and otherwise we do a CT, chest, abdomen, and pelvis for any metastasis. Now on MR, these are the sequences. We do large field of view, T2s, and so the pelvis, etc., is seen in a large field of view. Then we do small field of view. I'll come back to the small field of view subsequently. We used to do a few years ago some diffusion weighted also. Nowadays, studies have told us that there is no significant role of diffusion, and in our department we have discontinued, and I believe most of the departments have discontinued diffusion in rectal carcinoma. Now, if you see this case, you can see that there is a rectal carcinoma here, and so this is a different case and this is a different case. Now, key point is, how will you orient your axial slices? And this is one of the key things which you have to do correctly. If you don't do it correctly, you will get false results. So the orientation is that the axial slice should be oriented perpendicular to the long axis of the tumor. So for example, look at this one, it's tricky. The tumor is starting from here and going here. Look at this slice here. If it is oriented like this, you will get this type of image where the edge will not be seen clearly and you might get some false finding. The false finding I am going to point out shortly. So what we do is that we will scan this in this axis and then another axis like this. So your radiographer should be trained to pick that up and give you axials accordingly, according to the long axis of the tumor. Now, anatomy is the key. Please remember that there is the peritoneal reflection. It stops at a particular location, and if you see, this is a male pelvis. On this male pelvis, this is the prostate, this is the seminal vesicle. If you see, this is the peritoneal reflection. Peritoneum is coming here and then going here. And on this slice, it is beautifully seen. Look at this. This peritoneal reflection attaches here. So, distal to that is what we call the mesorectal fat and the mesorectal fascia, which I'll show you. But the peritoneal reflection is attached here. So this is a key concept, and this is an exam concept also. Secondly, the surgeons, when you're doing an MDT, will also ask you the same thing. So peritoneal reflection is attached here. Now, in a female, this is a female, in which you can see that this is the uterus, and you can see that the reflection comes here and attaches here. So anatomy-wise, we are interested from here downwards. This is where the rectum is. Of course, part of the rectum can be just here also, and then is the sigmoid. So here, distal to that peritoneal reflection, this is the anatomy. The anatomy is that this is the rectum, and this rectum does not contain a serosa. Remember, serosa is that peritoneal reflection. Serosa is finished. And then here is a fascia, and this fascia is the mesorectal fascia. And then this is the mesorectal fat. Now, key thing is, if you concentrate on this diagram, it tells you T3 tumor. So this is the mesorectal fascia. T3 is a tumor which goes into the mesorectal fat. T1 and T2 will be confined to the wall of the rectum. T3 will go into the mesorectal fat, and that becomes an exam case. If a tumor goes to a mesorectal fat, it becomes T3. On the other hand, if the tumor goes into for example, any other pelvic organ, we call it a T4. T4 will be blatant, it will be evident. But T3 is where you have to develop your eyes on. So, look at this. This is the tumor here, node here, and this thing all is the mesorectal fascia. This is the seminal vesicle. And if this tumor goes here, we call it is going into the mesorectal fat, becomes a T3 tumor. So this is the staging. T3 is invasion into the mesorectal fat. T4, invasion into the surrounding organs and structures, as well as the visceral peritoneum. So this question is asked in MDT. If you do an MDT with the surgeons at times where there is a high tumor in the rectum, this is what they are going to ask you. Is it superior to the peritoneal reflection or not? Key management question is, or management concept to remember for your exam is that if the tumor goes into the mesorectal fat, you do not do surgeries immediately. The concept is that you might like to do neoadjuvant chemotherapy or chemoradiotherapy. It all depends where you are working, because there are various theories in the oncology world. Usually they will give chemo for 6 months. So your report completely changes the management of the patient. And that is why you have to develop your eyes to pick up invasion of the mesorectal fat. And if you say it is invaded, then they will give new adjuvant chemo. That is the key management point. Another thing which in your report which you have to pick up is what we call extramural vascular invasion. Extramural vascular invasion. So what happens is that the tumor has gone into veins within the mesorectal fat. Radiologically speaking, how are you going to pick it up? You are going to pick it up as distension of the vein, which will be, just like a vessel, serpiginous, and then it can be in continuity with the tumor, or it might not be in continuity. Extramural vascular invasion, don't confuse it with a lymph node. Lymph node is different. Extramural vascular invasion is different. And there is a lot of literature and a lot of research also going on. And people say that if there is extramural invasion, then there is fourfold increase in risk of distant metastasis. And prognosis also is not very good. So prognosis wise also it from 74% to 35%. In our report, if there is extramural vascular invasion, you have to pick it up. Classical exam case, I'm expecting that the examiner will show you extramural vascular invasion, just to check your concept on that. Another thing before I continue is to see this tumor. We use the word, we call it intermediate signal on T2-weighted sequence. Classical tumors are like this, intermediate signal on T2-weighted sequence. They are not very high signal, they are not very low signal. So if I go back and I just showed you that metastasis, ovarian metastasis sitting on the rectosigmoid, and look at this signal, this is intermediate signal on T2. When you will cover, gynae tumors as in CS cervix, etc., you will realize that this will be the signal. So now, this is how we should report an MR of the rectum. First of all, what is the distance from the anal verge? Now, please remember that this thing, the surgeons should tell you actually that this is the distance from the anal verge. Having said that, you can also sort of infer it on the imaging. Then you have to say what is the craniocaudal and the transverse extension. The transverse extension is also what we call the depth of the tumor. So how thick is the tumor or how deep it is, it has got some prognostic value there. Is it going into the mesorectal fat or not? For me, this is a classical exam case, and what we are expecting for you to be shown is this thing, extension into the mesorectal fat. Now, from here comes this concept of distance from the mesorectal fascia. Now, if the tumor touches the mesorectal fascia, then we use the word it is circumferential resection margin positive. The basic concept is that in surgery, what they do is they just remove whole of the rectum, including the mesorectal fascia. So the mesorectal fascia, mesorectal fat, and the rectum comes out of it. When it goes for histology, the histologist will say that was the circumferential resection margin positive or not. If it is positive, means bad news, because you don't know if it has gone beyond it. If it is negative, it is good news. Similarly, these terminologies can also be used in pre-operative MRs. And the concept is that if the tumor is as close as 1 millimeter from the mesorectal fascia, we can use this word circumferential resection margin positive. And if it is more than 1 millimeter away, then we call it circumferential resection margin negative. Many people do not use these words, but they just report it. They say that the tumor is abutting the mesorectal fascia, for example, or say that it is only 1 millimeter from the mesorectal fascia. Now, any pelvic organ involvement, if it is a T4 tumor, then you have to say that, it is going into the lateral pelvic wall or whatever. Are there any mesorectal nodes? You have to tell this. Is there extramural venous invasion? Are there any pelvic nodes? So mesorectal nodes are, of course, around the rectum, within the mesorectal fat, and other nodes are, other chains like obturator chain and external iliac or internal iliac chain, etc. Now, anatomy, I have already told you that you have to have clear-cut idea of where is the peritoneal reflection, and in a male, this is the seminal vesicle. This thing goes here. So from here downwards is only the mesorectal fat and the fascia, and here onwards is here, and more proximally is the peritoneum. If the tumor is sitting here, please remember, if the tumor is sitting here, they will ask you, the surgeons will ask you that is it superior to the peritoneum? Is something going into the peritoneum? Because if something is going here, staging wise, it becomes something else, right? It is gone already into the peritoneum. So this anatomy is critical. And in a female, you can see that it goes here and it is attached at the same location, but from the cervix, from the junction of the cervix and lower part of the body, you can see the reflection. Now, this is the case which we covered initially. Now, candidate 4, are you with us?
Yes, I am.
Okay, now I will point out a few things. If you see here, first of all, we have to tell the examiner what is the distance from the anal verge. So what we do is that this from here to here, and first of all on a sagittal we decide where the tumor is or what is the distal most portion. So we add here to here on packs, and then here, for example, this is 3 centimeter and this is 3 centimeter. We say that it is about 6 centimeter from the anal verge, but please remember they should have already told you this. Then we measure the craniocaudal extent. So from here to here, and this, let's say we say that the craniocaudal extension of the tumor is 5 centimeter, for example. Then on a transverse cut, we say what is the location of the tumor. So this is the location. It is basically on the left side anteriorly and on the left. Maximum thickness is this much. This thickness is also what we call depth. Then is it going into the mesorectal fat or not? Now you have to concentrate because this is the key exam point. If you see here, you can see this whiskering of some high signal or intermediate signal going into the mesorectal fat. You can see the same thing here. You can see the same thing here. So this is classical where you say that the tumor is extending into the mesorectal fat. Now, from here, you have to, the next question is there any extramural venous, invasion or, venous involvement? And you can see something happening here. You can call this that there might be some evidence of, you see this is thickened and this is distended, and look how look at the shape. It is serpiginous. Then you have to tell that is circumferential resection margin positive or not. Now, if you see, this is the seminal vesicle, and this is the mesorectal fat, the fascia. Now, is where I am pointing out, is this a tumor? Is this tumor or not? If this is tumor, then it is going and abutting it. So you will say that there is circumferential resection margin positive. So, and then are there any mesorectal lymph nodes? Now, mesorectal lymph nodes, for example, this small dot might be a lymph node. In the mesorectum, size criteria wise, radiologically speaking, 5 millimeter or more is taken as abnormal. But if you see surgical studies, they tell you that even 2 millimeters can be abnormal. And a better idea is to use a criteria where a lymph node, if it has got slightly heterogeneous signal, this is T2, which has got two different types of T2s. And then if it has got an irregular outline, then you would like to call it abnormal. So these are the criteria to or the things which you have to answer in the exam or in your day-to-day reporting. So here I am going to show you a case, and then I will show you 3 odd cases, and we will finish the chapter. So I'm going to show you case in a what I call a PACS type of format. Candidate 4, can you see this green slide?
Yes, I can.
Okay, so this is a case of T3 tumor in a case which is 51-year-old male. So I am showing you an axial slice here, and I want you to see it with me. Now, on this axial slice, this is, of course, the bladder. This is the seminal vesicle. And you can see that this is the mesorectal fascia. And this is your tumor. Now, you can see till now, so I'm more distal. You can see actually the prostate here. And here, if you see the wall of the rectum becomes looks normal. And then as I'm going superiorly, you can see that the wall becomes thickened. And now see the signal, and you will appreciate that this signal is intermediate. Actually, this is more or less a circumferential tumor. It is, it is a 360-degree type of tumor. If just on this slice, if you see here, and develop your eyes on this one, look at this. We call it whiskering. You see, where I am pointing out, this will be the muscularis. So something is going out. If I just show you this slide, you can be confident enough of saying that there is whiskering and the tumor is in continuity with the tumor here. So it is going into the mesorectal fat. And with that, you can see this. Look at this structure. It is just like a vessel. Look here. It is just like a vessel. So these two are intramural venous vascular invasion. But the same thing here. For example, there is another vessel which is, and same thing here, same thing here. Now, if you look carefully, this is the mesorectal fascia, and this tumor here is abutting it. And even here it is abutting it. So I will say that this is a, just on this point, this is circumferential resection margin positive. Now look at the lymph node. This is one lymph node in the presacral space. Look at the signal intensity. Where I am pointing out the signal is slightly intermediate, and here it is slightly darker. And this is a classical example of a lymph node which is inward. So, so this is the axial. On axial, we have already concluded that this is a T3 tumor. There is vascular invasion. There are lymph nodes. Look at this one. This is also an irregular lymph node. You have to call it. And then it is circumferential resection margin positive. Now, going superiorly, you can see that rectum is just finishing and the tumor finishes here. And there is something here, but this something we will pick it up on a sagittal sequence. And then is the sigmoid. So we go to, here you are, there is another lymph node here. There is a lymph node here. There is a lymph node here. So these are those pelvic lymph nodes. Sorry, this one was not a lymph node. That was a vessel. So then we go to a sagittal. Actually, what I do is that I start from an sagittal, orient myself, and then I go to an axial. But because it had opened like that, I was just going through it. Now, if you see here, this is the anal canal. So from here onwards, you can measure this thing. For example, this is 3 centimeter plus this thing. You can say it is 6 centimeter from the anal verge. Then you measure from here till the highest point, which is here. And you tell them that the tumor is 7 centimeter in craniocaudal length. Now, key thing is, orient yourself about the peritoneal reflection. This is the seminal vesicle, and you can see that it goes here and it attaches here. So the tumor is, and then there is another attachment here. The tumor is definitely going superior to the level of the peritoneal reflection. Now, what they are going to ask you is that is the tumor going into the peritoneal cavity? If I go to the parasagittal here, and look here, so if I correlate it with an axial, which I cannot because I am not on PAX, if I cross-reference it, definitely it is going out here. So this tumor is going into the peritoneal cavity. It's much more than a T3, it becomes a T4. And then look at this, there is a lymph node here, and then look at these lymph nodes. This is a lymph node, this is a lymph node. And of course, the involvement of various vessels, for example, this one, this one, this one. So it goes into the peritoneal. Look at this tongue. And this is that tongue of tissue which we were seeing on an axial. And you can see that disregard everything, whatever is happening here, but just concentrate on this point. And you will appreciate that here the tumor actually is touching the mesorectal fascia. So just on this ground, it becomes a circumferential resection margin positive. So these are the things which you have to look for on a MR of the rectum. And candidate 4, I'm going to show you another case, and then candidate 5, I've got 1 or 2 more cases for you. This is the small field of view of the same axial which I showed you. And here, just see that this is the seminal vesicle. See that the tumor here, and you can see some whiskers going and abutting the mesorectal fascia here. Means that it is circumferential resection margin positive. And same thing here, because it is small field of view, you can see it much better. So so it is all a bad news, and you can see the the lymph node here. Now here in a PAX format, other than this rectum, I had also put a colitis case, and just to see that here is a CT scan. So for the time being, come out of rectal CA world, and you can see that You can see this is the transverse colon, and this transverse colon, there is mucosal thickening. So we will, this, I'm going towards the hepatic flexure, all mucosal thickening here. And then I am coming towards, this is the ascending colon and the cecum, and everything is thickened. On the other hand, if I follow it from downside, the rectum, the rectosigmoid, this was the sigmoid, and the ascending colon, etc., is all thickened. So, candidate 4, what it is, as far as pattern is concerned?
The accordion sign.
Right. So this is a pseudomembranous colitis type of a differential. Of course, it cannot be 100% specific. The same differential is that in the exam you will also say that it can be what we call ulcerative colitis and other infective colitis, and this is a coronal of the same. Okay, I put in some cases, and these kinds of cases come in long cases. They are unusual cases. I think I'll just skip it because of the time factor. But what we will do is that when we will do our long cases module, then I will show you these kinds of cases which come in the exam. Here, this is an interesting one because there is a abscess sitting in the lesser lesser sac, and it is communicating with the duodenum, and then it is communicating here. You can see this fistulous communication into the colon, and this is a duodenocolic fistula with abscess formation. So these kinds of cases, at times they come in long cases, and you have to do practice of scrolling them on packs and making the diagnosis. And in this particular case, when gastrographin enema was done, you can see that the fistulous communication into the duodenum and the stomach also filled up. It's a sort of a long case. In any case, I will now show you rectal CA. And then we'll go to candidate 5. So candidate 4 is, candidate 4, are you with me?
Yes, I am.
Okay, can you see my screen?
I can do, yeah.
Okay. Now I am going to ask you leading questions on this case, right?
Mm-hmm.
There is a rectal carcinoma which is going. Is the patient male or female?
I think I can see the seminal vesicle, so male.
Male. Now, there is a tumor which is quite a, in a craniocaudal dimension, quite significant. Is the tumor going proximal to the peritoneal reflection or not?
It is.
And which slice do you want me to point out for that?
Probably the top right, so the third sagittal.
Excellent.
Or even the second, either.
Yeah, very good. Well done. If you see, this is the peritoneum, and the tumor is going superior to that. Now, of course, without the cross-reference lines, it's very difficult to point out that at this particular location what's happened. But wherever we are here slightly more distal. What's happening? Is the tumor confined to the muscularis?
No, it's extension into the mesorectal fat.
Okay. Are there any lymph nodes?
There are some small lymph nodes, probably in the bottom axial, that slice just posteriorly. You can see So on the second image, I can see there's a node there. Yeah.
Okay, and you can relate with them. So let's assume that there was no extension into the peritoneal cavity here. So with that thing, what do you think is the T staging?
So it would be T3 then.
Okay, is circumferential resection margin positive or not? Maybe just concentrate on this one first of all.
Yeah, so on that one, it is positive because anteriorly I can see some whiskering towards the seminal visco.
Right. Sometimes in our reports, we just say most of the people use this word circumferential resection margin is threatened, or they say, the mesorectal fascia is threatened. This word is also in vogue, but never never make your assumption just on the basis of sagittal. Once you pick it up, then confirm it on an axial. Here, I don't think so I've given you very good axials correlating with this, but I believe even here it is touching. Okay, well done. Thank you, candidate 4. And candidate 5, are you with us? I'm going to show you 1 or 2 cases and then we'll go for a 5-minute break. Okay, candidate 5, are you with us?
Yep.
Okay, now male or female?
Male.
Okay, so of course I have written here also, and prostate, you can see a tumor here. Just concentrate on this. What is happening? Just on this slice.
So there's bulky thickening of the rectum with extension of an intermediate signal tumour out into the mesorectal fat at the sort of 7 or 8 o'clock position. The tumour appears to be extending to the circumferential resection margin, so would be CRM positive. On the other images, we can also see at least 3 intermediate signal lymph nodes.
Right. So if you see here, mesorectal fascia is involved. This is a slightly difficult sequence because it is axial, but it is a longitudinal type of an, coronal axial type because it is through the long axis. You can see multiple lymph nodes. Another concept is that if the lymph node is touching the fascia, again you will call it, because of the location of the lymph node, you will say that circumferential resection margin is positive. You think there is any venous invasion somewhere, or you want to, extramural vascular invasion?
I think on the last image in the bottom right-hand corner, there's a sort of thick tubular structure running alongside where the mouse is that could be suspicious for extramural vascular invasion, but
right. So please remember that it has been mentioned in literature that this finding is undercalled in our day-to-day reporting. And it's not important, as I told you, as far as staging is concerned, but prognostic value-wise it is. And they want us to report it because there are more than the chances of metastasis, for example, increases. Some of the tertiary care centers, like Royal Marsden Hospital, they are doing some research on this. And one of the hypotheses is that if you pick up extramural vascular invasion, then you should be more worried about liver metastasis. And here comes the sensitivity and specificity of a test. So some suggestion is that we should do an MR of the liver, and there they suggest just diffusion weighted MR of the liver, which is more sensitive tool than a CT to pick up small metastasis. Okay, Now, this patient had previous, prostate surgery also. So here, just on this slice, what is happening? There is a tumor here. Is it going into the mesorectal fat?
It does look like there's sort of spokes extending into the fat.
Excellent. Now, the question is, this is a low tumor. If you see here, this is the anal canal, and the tumor is from here to here, and at the anorectal junction, you can see it. Anterior to that, there is prostate, and this prostate also had some surgery. This patient had some surgery. The tumor is here. Now, please remember that this is mesorectal fascia, and next to that will be what we call the fascia of the Denenwiller, where, this is the external to the capsule of the prostate. Now, what do you think? Candidate 5, just orient yourself on sagittals. And what do you think on this slide? How will you call it? Is it going into the prostate, or are you suspicious, or you are not?
I'd say you'd be at least suspicious that it's extending in. You haven't got any sort of intervening fat there to call it as not extending into the prostate.
Right. So if you see here, this is the outer line, and you can see something here. So this is the capsule of the prostate, and even here. So at least one can raise the issue that it is suspicious finding. And what happens is that the surgeons, they will then, it becomes a very complex surgery if they want to do the surgery, and they would like to involve the urologist also during that. So it's a very important finding.